Welcome in everybody to the relaunch episode of the Strength for Your Purpose podcast. I'm Dr. Phil Finnemore, owner of WorkFitMe Mobile Physical Therapy, where we help our fellow Mainers build a resilient body that they can be confident in so that they can do more of what they love with who they love and perform in their day-to-day life like they need to. I am really excited to be relaunching the podcast. It has been a while since I've had a brand new episode out. We've churned out some sort of re-airings of episodes and stuff, but we have a completely new format now. Previously, we were all online and Zoom videos on the YouTube and everything, but we're gonna be doing this in person now, and I'm really excited to bring you this first guest of the relaunch, someone I've met very recently who's doing something really, really cool that aligns incredibly well with what I'm passionate about in healthcare, and you all are gonna love this too. I'm here with Dr. Jordan Leonard, owner of Agency Health, which is a new direct primary care practice here in Westbrook. So thanks so much for joining me and inviting us into your space.
Oh, thanks for having me on the inaugural relaunch. Excited to be here.
Yeah, fantastic. Well, we've talked quite a bit, and we've done a little bit of collaboration so far, and just really love everything you're doing. And for starters, we'd just love to have you just introduce yourself a little bit and tell us a little bit about who you are and your trajectory to where you are today here with Agency Health is a really cool story. So I'd love to start there.
Yeah, and it's probably a long story. I'll try to make it somewhat contained. But essentially, in terms of primary care or direct primary care, I saw this model probably in the late 2000s or like early 2010s when I was trying to navigate exactly what my next step was career-wise. At that time, it wasn't commonplace for physician assistants and nurse practitioners to be able to own their own practices based on state licensing and otherwise. And this was a model that I knew I wanted to adopt. I wanted to be an earlier adopter of this model, and I'm glad to see it finally gaining traction. But effectively, that's how I came into wanting to go to medical school, because at that time, physicians were really the only people that could own their own practices. So that's how I ended up navigating towards medical school, whereas I otherwise probably would have elected to go to PA school, just because the training sort of pathway is much shorter than medical school.
Sure.
And I was a little bit older getting into this. I was in my late 20s when I decided to go to undergraduate. So, 4 years of undergrad, and then I did 2 years grad school, 4 years of medical school, 3 years of residency training. So you can see how I'm sort of just getting underway now, even though this is a model that I've sort of aligned myself with about 15 or 16 years ago.
Yeah. I think that's the reason I wanted to start there is, well, one, we want viewers to know who you are, but two, it's incredibly unique for someone to get into the level of medicine you are as a DO, like you said, having to go through all of that schooling with this in mind, because this is so novel for this area.
Right.
Kind of another example of, and this is something I love and also don't love at the same time about Maine, is how slowly things like the revolutionary things like this.
It's a blessing and a curse.
A blessing and a curse,
Yeah.
Yeah, these revolutionary things take their time to get here, but when they do, they are so incredibly impactful. So yeah, that's an incredibly unique path to want to get into medical school and go through all those all the rigors of a program like that. What were you doing prior to getting into undergrad and then heading into med school to eventually get to here?
Completely unrelated. I was actually an iron worker for a decade in Massachusetts.
Okay.
And then in my late 20s, I decided to go. So I was an iron worker from 18 to almost 28. But at about 25, I had decided that, I wanted to try to go to medical school. So the degrees that I chose along the way, knowing that getting into medical school is a low percentage, proposition, all things considered, I tried to choose degrees along the way that gave me some sort of gain in the marketplace of employment. So in undergrad, I started out in athletic training, because at that time I was boxing a lot and heavy into physical fitness and kettlebell routines and things like this. So, and obviously sustained some injuries and head injuries as a result of poor choices. So went into athletic training, which gives you sort of at least some skill set in the marketplace.
Yeah.
There's jobs that only athletic trainers can do.
Right.
And then I had an unsuccessful first sort of stint trying to get into medical school. So I applied to graduate school. Again, I have a master's in biomedical research. So I could have technically gone on to be a bench researcher if I was not lucky enough to get into medical school, but on my second attempt, I was fortunate enough to be selected to have a seat in the class of 2020 for Midwestern in Glendale, Arizona.
Wow.
And just sort of stayed on the path, luckily, and sort of ended up here. I do want to start, you actually mentioned something interesting, that it's a sort of a blessing and a curse that Mainers, maybe are slow to adopt things. Interestingly, in my perspective, and maybe it's biased, but direct primary care is actually very consistent with the ethos of Mainers, right? They're very
100%.
autonomous, very self-reliant, independent people, and that's the entire spirit of direct primary care, right? It's about that independent spirit, breaking away from the medical system to sort of say, you deserve a higher level of care, a higher value care than you can attain in the what we'll consider sort of the conventional ways to consume healthcare in the marketplace. This is actually directly in line with probably what Mainer's ethos is. So
100%.
having them understand and recognize what it is, I think it'll take off pretty successfully here, I would say, in the near future.
Yeah, and it already is. People are seeing the value. I think you're right. I think there's a perception that Mainers are just like frugal, but they're not.
No,
they're willing to put their hard-earned money where they see the most value. And I've seen that in my own practice as well. And yeah, you're exactly right. I think it's less that Mainers are slower to adopt new things and it's more new things just take longer to like get here, because of some of those perceptions.
Yeah.
Right?
They have a good BS meter.
Yeah,
right? Yeah,
for sure.
Yeah.
For sure. I do think it's some of the perceptions of the people that would revolutionize a field like this, right? It takes more people to want to try it, and then someone to finally go, you know what, I'm going to give it a try.
Right.
And then it starts working, and then people really see the value. There's also another conversation there that we probably don't want to get into of other outside pressures in the healthcare industry and the reimbursement world and the third party payers that are pushing both providers and consumers, patients to this model. But you're right. It is taking off in Maine for the right reasons, and it's not just for people who have loads of extra income. I know plenty of people who would not fall in that category of I have a lot of discretionary spending money who still invest in something like this because they understand the value. And that seems like a really good segue. Let's jump into that a little bit. What, for those that maybe don't know, talk a little bit about just the general value of a DPC practice. And then I definitely want to from there get into more of what really sets agency health apart from the sort of blanket of the generalizations of DPC. But what to you, what are the most valuable parts of a direct primary care practice for the patient, for the consumer?
Yeah, you're really opening up a can of worms there. That's probably a lot to unpack. All of the general things that those are new to DPC or just starting to understand it, all of those things are true, right? The increased length in appointment times, the availability, the access to care, the freedom to test things that you otherwise maybe wouldn't be able to in a conventional setting. For me, I think it's a little bit more esoteric. So say, for example, we do a 90-minute office visit, which is unheard of, right, in the conventional product market.
Yeah.
But at some point, if we're talking about very nuanced medical things, and we're trying, like I was talking to our mutual friend earlier, to get 80% of anything is a relatively low lift, right? It's not that difficult.
Yeah.
A couple nuanced changes, a little bit of intentionality, you can get 80% of the way there. How do you go from 92 to 93? Lots of detail, lots of nuance. Yeah. Sometimes you're in the weeds, and through the process of all these conversations, there's going to be a point, especially as patients become more invested in themselves and more knowledgeable, that I'm going to have to tell you that I don't know.
Sure.
That's okay. I'm comfortable with that.
Yeah.
I hope the patient is as well, but I can't know everything.
Yeah.
Right. So it's impossible. But with a very low patient panel, right, we're going to have a soft cap at 200 people and probably a hard cap at 300. Right. Because I know that I can care for 300 people really well. Yeah. And it will be plug and play from there if I want to take somebody else on or maybe start referring them to someone else because I want to make sure that I can always offer the same value of care.
Yeah.
But where all that is going is essentially when I tell you that I don't know and you leave that consultation, that doesn't mean that it just ends, right? I have time to read. I can call a colleague. I can read some papers. I can, see a counter opinion to what mine is. And I can take the time to really unpack all of these questions and then get back to you with a more formal and sort of intelligent answer as to whatever problem we're trying to solve. And really, that's the critical piece, right? Is that your appointment doesn't end when the appointment ends, right? I have all the time in the world to sit there. If I'm only seeing 6 people a day,
right,
versus say 18 to 22 in a conventional setting, I have tons of time to really go in there and get back into the literature, refresh my memory, learn about an alternative perspective, see how that fits into the patient's goals, and then we can, re-navigate from there. And really, that's the crux in my mind. I know I don't expect really patients to think about it in that way, but as we get into really long-term risk stratification propositions, where we're talking about your health profile on a 40 or 50, maybe a 60-year timeline, you need some time to sort of work through all that, right? And that's really the benefit of a direct primary care, because we have the opportunity to take that. They say a full practice in primary care, direct primary care is 600 people. Like I said, I'm half that, but we're doing a lot of other stuff that's outside of, say, your conventional sort of primary care.
Sure.
But even if you weren't interested in all the VO2 max and movement screening and hang time testing and breath analysis, like all of this sort of stuff that we do, that is just my version of what I think good primary care looks like. You can still get all the same things that you would get from a conventional primary care doctor for very cheap in the marketplace of the DPC world. Right? You could be spending less than $1,500 a year, whereas if you were on the exchange, say as a small business owner with 10 employees and you're running on thin margins, you could potentially offer your employees at least access to some healthcare with some reasonable affordability.
Absolutely.
And they can get 90% of the way there with just a primary care who has the time to work through all of their issues, problems, questions, et cetera.
Yeah. Well, and you mentioned something in there that I want to kind of go back to, which is the idea that, patients might not see some of the value you see, and as far as, like you said, the visit doesn't end if I don't know. I have the time to go find the answer. And I think the patients definitely will see that, because a lot of the frustrations that I see are, and back in the day, people maybe saw this, but they ignored it, or the perception was, well, when I'm in front of my doctor, they should help me. They shouldn't say I don't know, like I'm coming to them because they're supposed to know. But I think that is shifting a little bit, and people really respect the, I don't know, but I want to find out for you. And people are starting to perceive in the more traditional model that the person they're going to see doesn't know, but they throw some stuff at them anyway. That doesn't really stick, or does not work, and doesn't actually solve their problem. And they're frustrated with that too, because they still probably had to pay for that visit.
Of course.
Because they got a high deductible insurance and they had to pay out of pocket for a visit that is a price of which is probably close to double, if not definitely double, than what it would cost them a month to see someone like you. And they get that time both in the visit and your time outside of the visit, doing the legwork to either find the answer or connect them to the person who has the answer, or has the service that is actually going to serve their need at the level they need it. And I'm seeing a big tide. There is a faction of people that would say, no, when I go see my doctor, they should have the answers for me and they should provide me an answer. I fall in that camp of sometimes the best answer they can give you is that they don't know. And that they send you to the person who does.
And, and I think that's the point, right? Is like, don't get me wrong, I want to know the answer. I've worked really hard to try to know the answer, but sometimes biology will always make a fool of you. Right. So it's incredibly complex. To navigate these little nuances in biology is very difficult sometimes. Sometimes you need time. Sometimes you just need an outside perspective. But to say that, I have all the answers, I have a friend who does very well for himself in Massachusetts, and we talk all the time, and I tell him that I probably know about 8% of medicine, and that might be hyperbolic. And he's like, there's no way that that's true. I'm like, it's probably true. It's
probably true.
Right. I mean, the volume of information that you would have to know is
when you get
endless.
When you get into the nuances of like each system of the body, like, come on.
And that's why there's specialists.
Exactly.
So, and as someone who's in primary care or a generalist, you're trying to navigate all of these systems in real time. And at some point you'll reach a complexity where you just have to say, I just fundamentally don't know. Here's what I'm thinking. Here's the 3 most likely things that it could be. Here's how we're going to attack it in the meantime, but let me do a little bit of reading. I'll call a friend, colleague, just sort of what they call like a curbside sort of consultation.
Sure.
Or call a friend who specializes in that. Like, what are you thinking? What am I not doing that I should be doing? Is there anything that sort of sparked in your mind that I should be attacking that I wasn't even on my radar?
Yeah.
And that could crack the whole case sort of wide open. Actually, again, I was talking to our mutual friend earlier, Andrew. Sometimes you get so deep into a case that you get so myopic and you're not seeing sort of the forest for the trees, and you go talk to a colleague and they go, did you consider this completely obvious and basic thing? It's like, oh,
no,
but that's the answer, right? It's just something so obvious, right? But you get sort of so tunnel vision sometimes that you just need a little bit of outside perspective to sort of, help you through the case. And that's okay. And that's why, just like life, medicine's a team sport.
Right.
There's no one on an island who knows everything, who could figure everything out. So, medicine's a team sport, and you have to be able to, have those resources available to you.
100%. Yeah, and I do think that really does add the value. I mean, the people at face value are looking for, more time with a provider, easy access from communication, knowing right out of the gate what something's going to cost them, right? Those are all problems in healthcare that the DPC model solves.
Right.
But I don't think it's until people start working with someone like yourself where they start realizing that the value they're getting is more than that, because it's behind the scenes and it's the time you have to be able to go do that's when they see the true value of what that direct care model provides. I definitely want to get into some of what you brushed over in there too, about what you do beyond what a lot of people consider typical primary healthcare. And I think some of that comes from your background in like your undergrad education, but also your training as a DO versus being an MD. So talk a little bit more about what parts of the agency are different that come from your background and your approach that sort of support some of what people might consider traditional primary care.
Yeah, and it's a good question. I would say at a 30,000 foot view, effectively everything we're doing, regardless of the modality, is risk stratification. Right? We're trying to risk stratify you and then minimize your risk for things that you may or may not be susceptible to. Right? Heart disease is the obvious one. Number one killer of all people in the world in the East and the West. So pretty reasonable place to start, right? It's a good entry point. Right? How do we mitigate your cardiac risk? But also, you see a lot of orthopedic injuries. We see how physical health correlates to mental health and sort of all of these things. So how are you moving? Basic question, right? Like, we've gone through a couple things with you in the screen. If you need to be able to complete a certain physical task, you need to have a lot of movement capability to do so. Right? And if you lose that ability, your sort of health span globally just plummets. Right? So when we start our sort of initiation process with a new patient, we actually start philosophically and have them sort of envision what they envision the final 10 years of their life like.
Wow.
Right? So if I'm lucky enough, I'll live to be double my age right now. So I'll live to be 88 years old. Well, that's 10 years beyond the average life expectancy of an American male. So that's a pretty heavy lift, right? I'm asking for a lot more sort of lifespan, if you will, but how are we living within that 10 years? So if we expect our health span, which is primarily made up of 3 different criteria, it's your physical health, your cognitive health, and your emotional health. Your physical health and your cognitive health will definitively decline over your lifetime. We're trying to take our foot off the gas, and if we're lucky, maybe apply a little bit of a brake pedal. There is no shelf life on your emotional health. You can continue to increase your emotional health throughout the course of your life.
Sure.
However, your physical and cognitive health are directly related to your emotional health, right? So how do we sort of slow that decline? So say I'm 85 years old, my son would be, maybe 45, 47, something like this. Maybe he has a son or a daughter. Well, do I want to get down on the ground and play Legos with them? If I do, what's my strategy to get off the ground at 85 years old?
How do I get down there and how do I get up?
And getting down there is a lot easier than getting up, right? And how do I stand up with just one hand posturing on the floor and standing up under my own volition versus sort of doing that slow roll into the couch and sort of all of this stuff?
Yeah.
Well, we sort of have to start thinking about that stuff right now and maybe our third, fourth, or fifth decade of life,
Yeah.
right, where it becomes exquisitely important to build that movement capacity and the degrees of freedom within these movement patterns that are all basic things, right?
Yeah.
You know, there's an entire field that's correlated to you, as just occupational therapy,
Right.
where sometimes you have to teach somebody how to get down to the level of a commode,
Right.
right? Because that's a squatting motion.
Yeah.
Well, so I'm just going to test how you do a squat and see what your ability is. And if it's not where we want it to be, you know, we're essentially looking for three things, right? Is there pain in that movement? Then we navigate entirely away from this at all. Or if you need a compensation in the movement pattern, but you can otherwise perform it with the compensatory movement, it's safe to load.
Right.
Or do we have a pattern that we've identified that it's not safe to be loading this pattern right now, and they need to get in, they need to C-fill, we need to correct all of this stuff before we start stacking weight on top of this aberrant pattern.
Right.
Right? And I can do a movement screen for you in 15 minutes.
Yeah.
So it really takes no time, and you get a lot of high value information out of that, right? Like, you know, we did a hurdle step with you at one point.
Yeah.
You walk upstairs probably every day.
Every day.
Right? Single level living in Maine is not really a thing.
No.
Right? You see either front to back splits or, you know, raised ranch or a colonial house. It's very rare to see single level living.
Yeah.
Right? Which is actually a common question in occupational therapy, particularly like if I'm trying to discharge a patient from the hospital.
Right.
You know, what's that sort of home environment look like?
Yeah.
So movement is essential, and you see people's mood and quality of life degrade starkly once their movement capacity starts to drop.
Absolutely.
All right. So to me, in a primary care setting, I think that's paramount that we know how you move so that we can give you some sort of corrective strategy.
Yeah.
And of course, strength is essential. So can we get you to a point where we load these patterns?
Yeah.
Right. All that stuff's critically important.
Yeah.
You know, another big thing that's big in healthcare, it's something that I see a lot in the hospital because I still work as a hospitalist, is people who fall. You know, I may get the statistics slightly wrong, but a patient over 65 who breaks a hip, within the first year after that hip break, they have like a 25 or 30% mortality.
Yeah. And
That's a preposterous statistic.
At around 70 or 75, it's a coin flip.
Yeah, you're talking 50-50 from you break a hip.
Whether you live or not.
Yeah.
From a broken bone.
Yeah.
Yes,
that
it's
is
stark.
That is stark.
Now, this is something that I want to throw in here because you've already sort of alluded to this, and this is why I love everything you're talking about here, everything you do here at Agency Health, is there are so many statistics that I think the medical field, the traditional medical field, take as fact and not as a guiding principle or a stepping stone to ask the next question or offer the next solution, which is, well, can we change that or not?
Right.
Right? It's just taken as fact. It's not taken as a metric, I guess, is the best way to put it. And unfortunately, the nuances of that, the providers probably know. But the way that they're explaining it to people in the 15 minutes that they're with them in the office
Right.
is, well, this is just how it is. That's might not be what the provider's saying, but that's what the patient hears.
Exactly.
I guarantee you
Right.
that.
Yeah.
Right? They hear, well, you're old, so you're going to fall. Well, you're old, so you're going to get weak. Well, you're old, so you're going to hurt. Well, you're getting old, so you're going to have arthritis. Because the providers don't have the time to go over the nuances of all of that,
Right.
and say, well, this is what we know, right? And this is why I think we're seeing what we're seeing with you, but here's what we can do about it.
There's always something you can do.
100%. Yeah.
A paper was just published. I think it was like strength training in people in their 10th decade of life. So all the patients were over 90.
Yeah.
Like some of them had no training life period whatsoever.
Yeah.
They were in a strength training program. They all gained muscle mass and strength in like an 8 or a 12-week program.
Yep.
And they're in their 90s, right?
Yep.
Your body is exquisitely adaptable.
Yep.
It will adapt to the stresses that you give it. So give it eustress instead of distress. And you'll probably end up being better off for it.
Yeah. Absolutely.
You know, there's often like a conflation between sort of fact and truth and all this stuff. This is probably maybe a little esoteric, but there is no such thing as scientific truth. Right? Truth is not a concept of science. It's a mathematical concept. It's a concept in philosophy.
Right.
But science is the removal of doubt. And that's like maybe a semantical thing, but it sort of changes the lens in which we view these things.
Yeah.
All of these things that we're doing are imperfect.
Right.
100% of them are imperfect.
Right.
Right. Even if you think about all the sort of science behind cholesterol and heart disease, fairly well established. Right. But cholesterol is technically still a surrogate marker. Right. Some people will go to the next step to say that it's causative, and their argument's actually fairly reasonable. But at a minimum, it's correlated. Right. So it's a surrogate marker.
Right.
But that's not a slam dunk.
Right.
Right. And not every patient fits into the same bucket.
Yeah.
Right. So you have to sort of be able to take the time to work through all of these things. We're stacking a bunch of imperfect, however, high fidelity, well researched things in order to give you our best guess.
Yeah.
And then we sort of test that in a way, right? We employ this intervention into whatever your health and wellness goals are, and then we measure the response.
Yeah. No, I think that is a really good point. I just saw a post today that is very typical of social media. And I think this is important to talk about because it kind of goes along with what we were just saying about, scientific facts, truths, things like that. These are all really like metrics more than they are facts, right? And I think what we're seeing in today's day and age is this convergence of people just seeing things online, right, that are presented with like this level of authority.
Yeah.
And they have no clue if the person presenting that has any authority to accurately interpret that metric, statistic, whatever. And then they're getting this mixed messaging or this very diluted down, minutialess factoid from someone who they do believe has authority.
Right.
And all of these things are converging to just like erode their ability to know what is the right information or where they should go with it.
Right.
And part of that is on people like us who are like posting stuff on social media like we have all the answers. I saw another provider today posting something that was like, oh, this thing, which is a new type of treatment for this diagnosis, is actually not recommended based on a systematic review. It's like, well, great, but the systematic review looked at that treatment alone by itself.
Right.
What if we combine it with other things that we know work, right? And that person is trying to market their service, right? Which is away from that type of treatment and more toward a different mode of treatment that we do know works for the problem that study was talking about. But again, it's never that black or white. It's never that black or white. We live in the gray. People want black and white, especially when they're looking for answers about their health.
Boy, and I wish I had it. But,
exactly.
I just
for
don't,
sure. For sure. But the important part is as you've already said, and this is what you do with Agency Health, is we are going to help you navigate that gray to make it as concrete as possible as far as what the plan is going to be to fit what your ultimate goal for lifelong independence and wellness look like.
And it's hard to, or at least for me personally, or you can hear probably in the things that I'm talking about directionally, like I'm hedging a lot, right? Because I started out from the outset to say that biology will always make a fool of you.
Right.
Right. So like when I'm on the academic service at the hospital and we're working with the residents, a lot of times, of course we're talking about, papers and interventions and the data and the application of this data and all this type of stuff. But philosophically, you have to have a framework as to how to approach medical decision making.
Yeah.
Right. Because like I said, biology will make a fool of you. Right. So you want to be wrong for the right reason. Right. So that you can recalibrate and sort of get your feet back underneath you and then start again.
Yeah.
Right? But if you're wrong for the right reason, you don't know, or excuse me, if you're right for the wrong reason, you just got lucky.
Right.
And when you eventually get unlucky, you don't know how to course correct.
Right.
Right. So it's about creating frameworks and directions of thinking in your mind, because like I said, you will unfortunately be wrong at some point. That's a hard reality to sort of learn, but you will be wrong at some point.
100%. Yeah. And you gotta, I always say I would much rather have a provider that knows what they don't know than a provider who thinks they know everything.
Unfortunately, I don't know a lot more than I know.
100%. And knowing that is incredibly important.
It took me a long
Incredibly
time
important.
to get there, right?
Yeah, for
'cause
sure.
you have all the, my Massachusetts bravado and,
Yeah.
type A sort of personality, which I'm sure you've heard my accent come out here and there, even though I'm doing my best to disguise it. But it doesn't, as you flare up my Irish a little bit, it doesn't always stay quelled.
Sure.
But all of that stuff is really just important, right? Biology's messy.
Right.
And risk stratification is difficult, right? But we're trying to take the highest fidelity, the most research information.
Yep.
And actually, you hit on something interesting there. What a lot of times you're talking about, like with this study and that study, you're talking about phase 3 people, right? Phase 3 trial participants don't exist in the community.
Right.
Right. Phase 3 participants are highly selected to find success within that trial.
Right.
In phase 4, where we exist in the real world, those patients don't exist.
No.
Right. So you're trying to apply this data.
The average person doesn't exist.
Right. Yeah.
Right.
Yeah. So we're trying to apply this data to then an individual that doesn't strictly meet the criteria of this thing. And that's where it sort of becomes messy, right? So we start to stack together all of these sort of imperfect tests to try to directionally get you going in the correct direction.
Yeah.
Where the DPC model offers you more leeway is that if, say, we didn't hit the nail on the head there, we have the time to recalibrate.
Right.
It's not you're coming into a traditional primary care office and you're the 10th visit of that day and the first 8 visits were just a disaster and the person's maybe not thinking to the best of their ability. They're a little frazzled and they're just trying to put out whatever fire you're presenting to them.
Right.
But in order to unpack all of that stuff, is it nutrition related, exercise related, sleep related, stress related? The first thing that you're trained to do in medicine is just review their med list. Or do we have you on a medication that's actually causing this problem for you?
Yeah.
And to get through all of that information in 15 minutes, I don't have that skill set.
Yeah.
Maybe some people do.
Yeah.
I don't have that skill set. So this is definitely the preferred model for me and what I think patients would ultimately benefit from.
Absolutely. Absolutely. So definitely want to obviously let people know how to find you and all that stuff. But before we do that, just real quick, take us through what a typical like first visit is going to look like for people, because you've mentioned some of these tests, and you don't have to go in depth over like every little test you do, but just to kind of bring it full circle on these different aspects of primary care that or the traditional aspects of primary care and the ones that you feel like are crucial that don't happen in the traditional model. What does that like typical first visit look like, and what are those things going to all culminate together to give you to drive that person's care moving forward?
Yeah. So in sort of the initial consultation, it's establishing what our goals are, right, and then seeing sort of where you're at with certain things. So, for example, we said we start in the last 10 years of life, right? Then we use just a simple system. It's called backcasting. So we sort of idealize a future event, and then we work backwards to the current, present time, so that all of our short-term goals are in line with that long-term goal, right? Everything is a feed-forward mechanism. And then we try to get an understanding of where's your nutrition at currently, right? Are you meeting your protein needs? Like what's your caloric intake for either maintenance or gaining or losing, depending on what your goal is.
Yeah.
What does your exercise regimen look like? Meaning what types of modalities you're using? How much time are you dedicating to certain things, right? Are you doing 30 minutes of weightlifting a day? Okay, can we augment that with maybe a little bit of cardiovascular exercise or otherwise? But what are you willing to dedicate to your training? Because I could tell you that 600 minutes a week is optimal. And maybe the diet flavor of the week is the best diet that we've ever seen ever, and there's no argument in the contrary.
Right.
If you're unable to adhere to these things, then it's a terrible plan.
Right.
Right. The best exercise regimen in the world is the one that you consistently do.
Yeah.
The best diet in the world is the one that you can consistently do, based on whatever your individual dynamics are.
Yeah.
Right. What's your sleep like? We can do a couple sleep questionnaires, try to get at least a framing the problem.
Yeah.
If you're someone who's interested in maybe like wearable data, we obviously want to interpret the wearable data cautiously and conservatively, but it's still an extra layer of detail that we can add into your sort of sleep paradigm. What's your stress like? Do you have any stress mitigating strategies? Right. So now we're sort of building this sort of framework as to how did you end up in my office at this time?
Yeah.
What inspired you to come in here? what do you want the last 10 years of your life to look like? And we work back to that point.
Yeah.
Then we get into the detailed lab analysis, right? We do a lot of cardiac risk stratification. We look at all sorts of things, hormones, thyroid, sort of all the usual stuff that even if things aren't out of balance or aren't optimized, we now have a framework. So say I'm lucky enough to see a patient under 30, probably less likely, right? Just because they're invincible and they're not old enough to have problems yet. But once they hit that 30 and 35, and that now they've been in a career for a decade and sit behind a desk, and they haven't had their assessment by you for their ergonomics and all of this type of stuff.
Sure.
They could be already not really feeling that great at 35.
Yeah.
So then we do all your detailed lab work. If we happen to pick out something genetic or something in their lab work that needs addressing, right? I guess I'm one of those dinosaur physicians who thinks cholesterol matters, and basically because the preponderance of evidence is in that camp, so it's a reasonable position to take.
Sure.
Or if you have a genetic predisposition to the things with like Lp(a), which is finally actually starting to gain traction, which is nice.
Yeah.
Even though when I was in training, every cardiologist yelled at me for wanting to test it in patients, and now it's like the new lexicon of the ACA guidelines.
It's like the new gold standard.
Yeah, exactly. So
risk stratification.
So they're just maybe not up to date on the literature because it's hard to do that as an attending.
Yeah.
So now we have sort of your philosophical goals and sort of where you are, what your habits have been, what you've been dedicating to these individual sort of parameters.
Yeah.
Do all your lab work. Then we'll do sort of a second visit. We'll do your VO2 max, your hang time testing, your movement screening, your breath analysis, your entire physical exam, and just try to get a sense of what your body moves like, what it has for capacity, what it has for degrees of freedom within these movement patterns. I'm going to put you into disadvantageous positions, a position that I would never encourage you to squat weight in.
Right.
But I'm encouraging you to squat your body weight into it because I want to see if you have sort of the degrees of freedom to get into this position, even if it's disadvantageous.
Right.
We sort of pool all of that stuff together, and then sort of either what would be your third or your fourth visit. Now I have all of your data, all of your goals. I know what you move like. I know what your cardiorespiratory fitness is. I know what your labs look like, your risk stratifications. I've calculated all the scores. These are your risks of heart attack, stroke, MACE events, all of the diabetes, all of these types of things.
Yeah.
I present that to the patient and then say, I always try to start with the lowest hanging fruit.
Yeah.
Right? What's the simplest thing across all things that we're interested in, nutrition, exercise, sleep, stress management, et cetera? What has the most overlap amongst those? Let's start right there, right? Because that's going to give us the most broad sweeping benefit. And then as the patient becomes more invested and they want to get from 93 to 94%, all right, let's really get into the weeds of all of this data that we've already collected and that we continue to sort of reanalyze as your body changes with time. And then we can find these little nuanced adjustments from here.
Yeah.
So that's probably like a convoluted way of saying it, but there's a lot that goes into getting, so when you're talking about health, your health span over a 60-year period, you have to have information to make decisions on. So 100%. We try to collect as much as possible.
Yeah. No, I don't think it's convoluted at all. I think it actually paints the picture beautifully of what you get, because everything you just said that happens over 2 to 4 visits as someone onboards as a client of yours would be probably close to 8 to 10 separate office visits in a traditional model. And if you didn't have what they believed, or actually what the insurance company believes,
well, that's
a legitimate reason to investigate some of those things, they wouldn't even investigate it.
Right.
It's not convoluted at all. It's exhaustive in a good way. Right. It's an exhaustive list in a good way, because you're right. That is what medicine should be. That's actually healthcare. Our current healthcare model is sick care.
Right.
What you just described is healthcare, where we're building a case essentially.
Exactly. That's what we're doing. Yeah.
We are building a case for you to be able to fulfill your ultimate goals throughout your lifespan.
Right. And you've defined your goals for yourself, right?
Yeah.
It can be a little sort of heavy to think about, like, the last 10 years of my life. But again, if we just sort of shift our focus a little bit and to say, well, actually now from the present time, I can do the things that matter with intention, whether it's my social connections, my relationships, my training, my nutrition, et cetera.
Yeah.
You're actually able to do it with intention.
Yeah.
Some people get to the end of life and they haven't thought about any of this stuff.
Yeah.
You know, one of the reasons why it's called agency health, as you've been alluding to it, is that you don't really have autonomy in the conventional system. And I want my patients to be invested in their sort of health and wellness goals.
Yeah.
Right. And they need agency to do that.
Yeah.
Right. Versus having not even just, even if the physician you're seeing disagrees with you, or say they agree with you wholesale.
Right.
If the clerk at the insurance company disagrees, then you're kind of like up a creek, right? There's really not much you can do. You don't have the autonomy or the agency to do that.
Yeah.
And the reason why I try to focus on all these things is because in my experience at the hospital, I see patients often, you know, in their 8th, 9th, or 6th decade of life, you know, pretty routine, as a bread and butter hospitalist. And whenever they have either a progression of a diagnosis that they already carry, or they're getting a new diagnosis that's going to change how they live their life going forward, and you start to have these goals of care conversations, you find out pretty quickly what's important to everyone is the same thing, right? I was a medical student in Arizona. I trained in New York, you know, Massachusetts, and now Maine. So I've seen sort of a broad scope of different people, all races, all creeds, all different socioeconomic statuses. They all say the same thing. They want autonomy and to be independent as long as possible.
Yeah.
Right. So longevity is like a big buzzword in the social media space. Like conceptually, I kind of know what you mean, but it doesn't really have any meaning.
Yeah.
And frankly, if you frame it from the perspective of, do you want to be 90 and bedridden in a home?
Right.
Or do you want to be like robust 85 and then call it quits?
Sure.
Right. Like most people would choose quality over quantity.
Right.
And that's really the mindset behind this long-term independence.
Yeah.
Now, as a symptom of all this great work that we're doing, or really the patients, right? The patients are putting in the work.
Sure.
If the symptom of that is they also live longer, that's great.
Right.
That's fantastic.
Yeah.
Right. But the main goal is to be upright and well as long as possible.
Absolutely.
Because when my son has a child, I want to get down on the ground and build Mark Rober sets. Do you know who Mark Rober is? Yeah. Mark Rober is the best, right? And we get like his monthly sort of boxes, and every time it comes, we're super excited to get down on the ground and just put it together.
Right.
I want to do that with my grandkids.
Yeah.
You know, and if I'm lucky enough, my great grandkids.
Sure.
Maybe not because I had kids later in life, but you know, if I'm really fortunate, you never know. You know, like I said,
if the biology lines up. Right?
88's a heavy lift.
Yeah,
you know? But my grandfather's still alive, and he's in his late 90s.
Yeah.
And he's strong as an ox.
Yeah.
So, but that's not the norm for my family tree.
Yeah.
You know, the family tree usually breaks off in their late 60s, early 70s.
Oh,
right?
wow.
So he's sort of the
outlier
there for sure.
Yeah.
But so that long-term independence, right? And that's really there's no better example of that than Mainers. Yeah. Right? They have that autonomous, independent spirit.
Absolutely.
Right? And you know, where that comes from, it's just probably, you know, a combination of things, right? That sort of Puritan ethos that migrates throughout the entire Northeast. You know, that sort of live to work type of mentality, right? They're hard-nosed, hard-working people, you know, and you kind of alluded to this earlier, but they want the value. It's not that they're slow adopters, is that they bust their butts. Yeah. If they're working outside, the weather's brutal. Yeah. You know, I mean, I love it. Like, I love winter, I love fall, like I like the seasons. Yeah. But I worked outside for 10 years. I know that it's brutal to be on a roof when it's 120, or, you know, we did a job in the Cape of Massachusetts one time, and it was like minus 40 at Otis Air Force Base. Right. You know, it's like, it's not always the best, right? If you're working that hard for your money, you want to get the value out of it, right? You don't want to just start blowing your money. Right. And I would argue that, at least from the primary care perspective, the conventional medical system's exquisitely low value. Yeah. Right. I still think that there's great things about the system. Sure. And great providers working in that system. Oh, absolutely. Yeah. I mean, I've just met so many great people, you know, throughout the country, you know, at all levels of healthcare, who are just, you know, changing people's lives, you know, from patient to patient. It's 100%. Remarkable. But from a primary care perspective, I do not think that you can obtain anything of value in the conventional system. Yeah, absolutely. Couldn't agree more. Well, thanks so much for your time in doing this. This is incredible. I'm really excited for you. I'm really excited for everyone that's going to get to experience what they're going to experience working with you and Agency Health. Before we wrap this up,
how can people find you? How can people get more information and sign up for the incredibly valuable services you're going to provide as their direct primary care provider?
Yeah, all the usual stuff. The Agency Health at Instagram, I think it's connected to a Facebook thing. So there's probably, as you know, like on the back end, we sort of do it through one service. But so the Agency Health there, theagencyhealth.com. Plenty of information there. You can reach out to me for information for whatever you need. Text or call. There's no barriers to me, which is, I think, not to go on another tangent, but I have a patient portal. I have emails. My patients just text me.
Yeah.
They text my personal cell phone.
It's great.
Right. There's no medical assistant. There's no nurse. There's no admin assistant. There's no biller. There's no coder. It's me and you.
Right.
Right. So you just text me, and if I don't know the answer, I'll find the answer.
Yeah.
Right. No big deal. But so all the usual stuff, social media, the internet, the Agency Health, you can search for me by name or by the practice name, and all the usual stuff. And if it's not for us, but you feel like you still want, if my service is not for you, that's perfectly okay. I know with the more niched things that we're doing, my service isn't for everyone.
Sure.
But there's plenty of people who are in the same model who are offering different modalities and otherwise that you may get the value out of. And as long as you get to where you're going, right, and you achieve your goals, that's all I really care about. Of course, I would want you to, believe in my service, but ultimately I recognize that it's not for everybody.
Sure.
But for those people who it's for, I think we can start something pretty positive here.
Yeah, great. Well, I'd encourage everyone to go follow Dr. Jordan Leonard, the Agency Health, on social media. We'll make sure we link all that stuff down below in the description of the episode and the video. Please like and subscribe to the podcast on your favorite podcast platform here on YouTube. We'll love it if you share it with someone who you thought of while you watched or listened to this that will find this information valuable. Really excited to be relaunching the podcast. Thanks for helping me.
Excited to be here. Yeah,
thanks for helping me do that. And we will see you all back here next time on the Strength for Your Purpose podcast. Go make it a great day.